Welcome to the October 8th meeting of the Board of Directors of the Washington Township Hospital Township. I'd invite you all to stand with me and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Christine, if you'd take the roll for us, please.
Sure. Director Stewart.
Present.
Director Wallace.
Present.
Director Nicholson.
Present.
Director Danielson.
Present.
Director Epen.
Present.
Thank you.
Thank you, Christine. Our first item on the agenda is an educational session. We're going to have Chris Henry and Mike McBride present the audit for the year. If we could have Chris do that.
I thought I
I'm
would
sorry.
begin by introducing Mike McBride. I
Yes.
know that he's well-known to the Board of Directors and to the management team, but for our viewers in the district, I thought that an introduction is appropriate. He's a partner in the healthcare assurance practice in the Western Region Healthcare Practice of PricewaterhouseCoopers. He has over 29 years of experience working with healthcare clients, including academic medical centers, integrated health systems, acute care and long-term care facilities, and physician groups. He's been responsible for and coordinated a wide range of audit and business advisory services, including financial feasibility studies, demand and market analysis, merger and acquisition studies, assisted in the internal audit outsourcing for a major regional teaching hospital, integrated delivery system, due diligence reviews, and numerous accounting-related projects. He's a member of the American Society of Certified Public Accountants. He is certified as a public accountant in California, Connecticut, New Jersey, and New York. With that, I'd like to turn the meeting over to Mike.
Good evening, everyone. I guess I'll try to make this as educational as possible. If you can make an audit educational. Excuse me. So tonight I'm going to talk about really what the scope of our audit was. I'm here to present the results of the financial statement audit for 2014. That's what we were hired to do. We are done with the audit. We anticipate issuing our opinion in the next couple of days. As a result of that audit, we're not aware of any material modifications to the financial statements that need to be made at this point. We're not aware of any material weaknesses or significant deficiencies in controls. As a result of this meeting, I'm not aware of any actions that need to be taken by the board. But as I go through the results of the audit, what I'd like to talk about is some of the risk and response summary on how we look at audit risk through our lens. I'd like to talk to you about some of the areas of focus, the approach we took and the results we found, and the required communications that my profession mandates that we have with an oversight board. So up here is the summarized statements and net position. For those of you that aren't familiar with the Governmental Accounting Standards Board vernacular, this is the equivalent of a balance sheet if you're used to looking at it in terms of a normal corporate set of financial statements. And here it presents total assets, total liabilities, net position, which is the equivalent of equity. And the other two lines that I'll talk about in a minute, you have deferred outflows and deferred inflows, which was really a unique kind of presentation that is you'll see in governmental accounting standards. The statements of revenue, expenses, and changes in net position, again, the equivalent of that in a normal kind of corporate environment would be the profit and loss statement or the income statement. And here you can see comparatively from 2014 to 2013, just going right to the bottom line here, a loss this year versus a nominal profit last year. Just some anecdotal kind of commentary around that. When you think about where healthcare is going, there's so much pressure on the top line. It wouldn't surprise me at all if you're going to see some organizations in this state and across the country continuing to experience some challenging fiscal times prospectively. Risk and response, I'm going to educate everybody on how an auditor thinks here. The way we scope an audit is we look to see where we see the risks in the financial statements, and we respond to those risks through different types of audit tests and procedures, okay? Significant risks get more attention, normal risks get less attention, but certainly because they're quantitatively material, we do spend the right amount of time that we believe is necessary to get us the right level of audit comfort. The top two, fraud risk and revenue and management override controls, what I would tell you is that that's a presumed risk on every audit that we do. Okay, we are trained to think, to be paid skeptics, and where could things go wrong, where could management override those controls. The third is, which I think is unique to healthcare, which is around valuation of accounts receivable, okay? Because of all of the complexities around collections, the different payer contracts, the risk involved in the revenue cycle, we view the valuation of accounts receivable to be a significant risk. So we look to make sure that those estimates that management has put in the financial statements at year end are reasonable and appropriate and without bias. Two new accounting standards that impacted this organization this year. The first, quickly, GASB 65. Under prior accounting models, costs that were incurred in the issuance of debt were allowed, actually not allowed, they were required to be capitalized as an asset and then amortized over the life of the debt issuance. Similar to what happens in the non-governmental space. The Governmental Accounting Standards Board reevaluated that and said now those costs need to be expenses incurred. So management adopted this standard this year. Any of the costs that were incurred in prior debt issuances were written off this year. The impact of that was to reduce the net position by $2.5 million. The other accounting standard, and this has obviously gotten a lot of press over the last year, year and a half or so, is the Government Accounting Standard really undertook a project to try to improve the transparency and the financial reporting over obligations to, promises to its employers, both past and present. In the past, to the extent that there were over or underfunded pension plans, those were just disclosed in the footnotes. Unlike the financial account, the corporate world, which actually puts those liabilities or assets right on the balance sheets of the organization. So the core principle, if it really was, to provide its citizens of the governments, including an organization like the district, more insight, more transparency into the reporting for these things. So the result of that was, and by the way, the reason I'm talking about this, obviously, is the district adopted this accounting standard this year. The result of that was to increase the pension obligations as of the beginning of the prior year, because anytime you adopt an accounting standard, you go back, because we have comparative financial statements, so you want to make sure those two are comparative. Go back to the beginning of last year, add to the obligation $133 million, and then flow that through to the current year. Since that time, certainly the organization had assets set aside to make that funding, and they've since funded that to get that obligation way down as you go through to the end of 2014. The other piece of that is that GASB mandated now was it did impact how actuaries calculate the obligation. Some of those changes actually resulted in a reduction of the net pension expense by about $2.5 million. By the way, I will tell you about this standard here. The district is probably one of the first out of the gate to adopt this. I would expect this is actually required to be adopted next year for all governments. So as you go through and see this, I think this will be a big impact to a lot of governments as they adopt this standard. The other area, and I talked about it earlier, the valuation of accounts receivable are a significant risk. So up here I put together just a quick highlight of patient accounts receivable and the related allowances. You can see the gross patient accounts receivable, which is really just the accounts that are open at June 30th at the organization's charges. Then to get those down to what anybody's going to pay them, whether it's Medicare, Medi-Cal, or the various insurance companies, that's the reserve for contractual allowances. And then the allowance for bad debts, these are people who have the ability to pay, who are expected to pay, but don't pay. And it gets you down to net patient accounts receivable. Those numbers with brackets are really where the estimates are, and that's where we spend a lot of our time. The other analytic I point out here is you can see the days in gross patient accounts receivable actually went from 58 to 69. One of the big risks that exist in these accounts here is there is about $5 million worth of receivables open from the Alameda Alliance. And if people have read the papers really dating back to April and May, Alameda Alliance right now is in an element of receivership, so there is some risk there. I think management's appropriately addressed that, but this is one where I think, stay tuned as facts and circumstances change. It could result in some swing in those estimates. So what do we do to get comfortable with all those numbers I just talked about? We certainly go through a process of understanding the methodology used. We update our understanding of that. We look at, are there any more risks this year versus last year, and how do those changes in risks manifest itself into the valuation models? And the other thing we do is we validate how good has management been, proven themselves to actually do reasonable estimates. So we look back to the prior year, because we've got 20/20 hindsight this year, and compare that. So we've got actual results, compare that to their estimates. You see in here that I talk about that they were within 0.8% of their estimate, which in our world is pretty much in the middle of the bullseye. Then we go through a series of analytics and detailed testing, all of which are listed here. The other thing that I would point out here is this organization's now up and running on Epic, its new clinical information EHR system. This is a big event. And, when I think about how to get comfortable, we no longer, as an auditor, I don't have a piece of paper. It's an electronic medical record. So the way we get our audit comfort over that is to look at the controls around the IT system to make sure that the system is well controlled so that only those appropriate people can access and use that system. And we did that, and we had no issues around the controls there. And as you can see here in the results, I had no exceptions as a result of any of the detailed testing I did, and I believe that management's estimates are appropriate and reasonable. Cash and investments, this roughly about 4% of the total balance sheet. I'd say from an audit risk perspective, there's not a lot of complexities in auditing cash or even investments for that standpoint, but it is a material number. We do confirm 100% of this with depository institutions. Anything around value, if there are investments held, we reconfirm and reperform the valuation testing of that. And we also make sure that to the extent that financial statement institutions are required to have collateral because you're a government, we do confirm that collateral to make sure that the California code sections listed here have been complied with. And again, no exceptions noted. Self-insurance and other actuarially determined liabilities, kind of a mouthful. But these are where if an organization is self-insured for risks, what this one is, employee health, workers' comp, and certain professional liabilities, to the extent that there are actuaries involved in that the organization reaches out and hires actuaries to come up with their estimates. We actually have actuaries as part of our team to validate that. We get comfortable with all of the underlying detail that your actuaries have used. We reperform that. We have our actuaries validate that the methodology used was appropriate, and we also perform independent testing over that. And in addition, as I talked about earlier, we also made sure that GASB 68 was appropriately handled. GASB 45 really speaks to, there is a post-retirement health benefit plan here. That really speaks to GASB 45. We also look at that plan and make sure that that's been accounted for and reported appropriately. I will tell you that the GASB is looking at OPEB plans, the other post-employment benefit type plans. They have not done that. Are they going to move to kind of taking that underfunded and putting it on the balance sheet? I can see them moving in that direction. But when you're dealing with the Government Accounting Standards Board, they move pretty deliberately. So I'd expect that to be a number of years out. Other significant areas, capital assets, the other, I'd say, major bulk of the balance sheet from an asset perspective. We look at any invoices around here. The risk here is that I don't want the organization putting inappropriate things, taking expenses and putting them in those fixed assets. We look for that to make sure that they've done that appropriately. We look at the calculation around anything on capitalized interest, reperform anything around depreciation, and again, no exceptions were noted in that area. Debt, other than confirming it, to me, the area that I focus in on is really their compliance with debt covenants to make sure that, because if you fail a covenant, that's a big deal. So we actually look at the covenants embedded in all the debt agreements to make sure that they've complied with those, and again, no exceptions were noted in that area. Accounts payable, accrued expenses, really just a lot of detail testing for us. Net position, to me, it's about classification within the categories there. Not Not a big audit risk, but we still do make sure that it complies with the governmental accounting standards, and again, no exceptions there. Revenue testing, this is a big area of focus, and the way you get comfortable with revenue, we do pretty large samples. I think if you ask the people that were in medical records or in patient billing, the samples were probably a little bit too large. But nonetheless, we do a lot of testing there. And our testing goes all the way from making sure the charge was appropriate for a patient, that the patient existed, the charge was right, it agreed to your price master or your charge master, all the way through to the billing process to where we can see the cash that was collected in the bank statement. So it's a very thorough end-to-end process over a pretty significant sample. Operating expenses, again, I'd say, when you think about the operating expenses of a hospital, payroll, drugs, insurance, space-related costs, these are all subjected to detailed testing down to the invoice level, in significant samples just to make sure we're comfortable there, and we didn't have any issues in this area at all. The medical foundation, the principal area here is there are revenues that are generated for the medical foundation, so it is a different revenue stream. So we do look at that differently. There's around $20 million of revenue flowing through here, and we detail test that. The outpatient surgery center, two things here. Again, they've got a revenue stream there that we do subject it to detailed testing. There's also an element of goodwill that we look to. Goodwill accounting is one of those where you look just to make sure that it hasn't been impaired in any way, and this year it was not impaired. And then certainly the presentation and disclosure. While I can't sit, one of the things that I've talked about with my clients is around, are the financial statements transparent? Are they telling the reader what it needs to tell? While I can't tell you that there's a particular objective standard that I look to, I do look at it critically to make sure that the disclosures are appropriate, and I do believe they are. The last thing I would tell you here, and I bulleted out here, these are the type of communications that my profession requires that we have with boards and oversight committees, and you can see them here, and I'm just going to talk about a couple of them. Fraud and illegal acts, this is an area that is a top-of-mind focus for my profession. Part of it's driven by that, if we've all read the newspapers, unfortunately, frauds just continue to rear their ugly head in corporations and organizations. So we do design tests specifically to try to detect material instances of fraud, and that includes detail areas where I think management can override controls. We do unpredictability. I don't want management getting comfortable with the way I audit, so we make sure that we keep them on their toes by doing a level of unpredictability. And the other areas, we obviously look for any elements of bias in the financial statements where management could try to, what I'll call, manage the earnings, manage the financial statements, and we didn't have any instances of that whatsoever. In terms of moving down, material uncertainties related to events or conditions, specifically going concern, I'm not aware of any events at this organization that would preclude its ability to continue as a going concern. Controlled deficiencies and identified misstatements, again, from a control deficiency perspective, no material weaknesses, no significant deficiencies. Disagreements with management, this is one of those that, audits can be challenging, but here I'm happy to report that we get the full and unfettered access to all the books and records and all of management. And by the way, the board has been very cooperative as well, so I appreciate that, because we do need to make sure we have open access in order for us to complete our job. And then the last one I would touch on here is departure from our standard report. We will be issuing what I'll call a clean opinion, so there are no departures from our standard report whatsoever. So I went through that rather concisely, and hopefully everybody got some element of education. And I'm open for any questions. So thank you. Thank you, and I appreciate the opportunity to be here.
Mike, we really appreciate your work on that, and we appreciate the work of Chris Henry and his group of people. It's nice to have a clean audit. It's wonderful to have a clean audit. It's unfortunate when we have to report a $10 million loss, but that's your job too.
Correct.
And when I first joined the board 12 years ago, hospital work and hospital reimbursement was a much different ballgame than it is now. And we're in a totally different world that is getting more and more difficult as the days go on. Appreciate your report. We're striving to do what we can to improve that bottom line. Any other board members have comments for Mike? Mike, we appreciate your work.
Thank you very much.
very much.
Okay, good evening.
At this point in time, we're going to change the order of our agenda slightly. I'd like, at this point, to take up the action item for the audit report. And Dr. Epen will present that. That's item A on our action items. If Dr. Epen could do that, that'd be great.
Mr. President, I move for acceptance of the audit report for fiscal year ended June 30th, 2014, as presented, and the secretary be directed to publish the report in the newspaper of local distribution in accordance with the local hospital district law and hospital policies and procedures.
We have a motion and a second. Are there any comments from the public on this item? No other comments from the board, then we'll take a vote. Christine?
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Danielson.
Aye.
Director Nicholson.
Aye.
Director Epen.
Aye.
That motion passes. We can move on now to a consideration of the minutes of September 10th, 15th, 22nd of 2014. Could I have a motion on that?
Move for approval as presented.
Thank you. Do we have a second?
Second?
We have a motion and a second. Any discussion on that item, either way? Thank you. We'll now take a vote. Christine?
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
Good. That motion passes. We'll now move into our, on the,
Minutes, the roll call.
yes.
we do a roll call?
Yeah, we did. We'll now move on to our communications. We have first oral communications, and first of all, I'd like to open that to have Nancy Farber, our CEO, make a statement as far as oral communications.
Dr. Stewart. This evening, I'm going to do something that I don't ordinarily do. I'm going to discuss labor negotiations before they've come to a successful conclusion. Given recent events, the hospital is compelled to provide an update to both the board and the residents of Washington Township Healthcare District. We pride ourselves at Washington Hospital for treating everyone employed within the healthcare system with fairness and respect. We consider our employees among our greatest assets. Recently, we've had to make a very unfortunate decision about staffing that resulted in direct layoff of 31 individuals. The difficult choice was the last resort and necessary to respond to decreasing patient volumes and to ensure we continue our ability to provide as many represented jobs as possible. In fact, Washington Hospital is home to 6 different unions and considers those in our represented workforce as our partner in providing the best healthcare services available to our community. Currently, we're working diligently to come to an agreement with SEIU UHW Local 250 on a new contract. However, in recent days, SEIU UHW has opted to run advertising that is based on half-truths and outright distortions of facts. SEIU UHW has portrayed Washington Hospital as an organization that does not care about its employees or its patients. Nothing could be further from the truth. Also, contrary to what's been stated, taxpayers are not taxed to fund hospital operations or to pay for the salaries of anyone at Washington Hospital, including the CEO and its leadership. While we believe the union's tactic is inherently unhealthy to ongoing discussions, we will continue to bargain in good faith, as our number one goal is to provide fair compensation and benefits for all the employees of Washington Hospital, including those represented by SEIU UHW. You may be interested to know that our discussions have not centered around wages. Washington Hospital has a long-standing wage policy to pay all employees a fair wage that is neither at the top nor the bottom of the market. In fact, 90% of the SEIU UHW represented job classifications at Washington Hospital are paid at or near the top of the range when compared to all other hospitals in the Bay Area. We believe that those who live here deserve to be cared for by the most talented employees in the Bay Area, and our compensation philosophy helps us attract the best and the brightest. Discussions have stalled over our requests that employees, including those represented by SEIU UHW Local 250, pay a small portion of the premium costs for providing benefits to cover a spouse or a family member. Employees who only need coverage for themselves will continue to pay nothing towards premiums for benefit coverage. Employees who are sole providers, making less than $55,000 a year, and need coverage for a spouse and family will continue to pay nothing for premiums. You might recall that this was recently called to our attention in comments from a Washington Hospital employee at the August 13th board meeting. She stated that she was a sole provider at the lower end of the pay scale, and any contribution would have been a financial hardship for her and her family. Her words reached me. I listened to her, and so I asked the negotiating team to make this change, and they did. Overall, the contribution proposed is extremely modest compared to what the hospitals in the Greater Bay Area require their employees to pay for premiums to cover the employee only, or to provide coverage that includes their family members. And I think we could be subject to a fair amount of criticism for not being good stewards of the district's assets by not being aligned with the market. Currently, we're completely out of alignment with the market. There isn't another hospital that doesn't request some payment for premiums and receive them. Currently, Washington Hospital pays nearly $2,000 a month to provide full medical, dental, and vision benefits to each employee and their family. There are no premium costs to the employee. We believe our proposal is fair and reasonable. We're asking our employees including all non-represented employees and management staff, which includes the CEO, to contribute the following: $29.12 per paycheck to cover an employee and their entire family, $15.87 per paycheck to cover an employee and spouse, $13.29 per paycheck to cover an employee and children. No cost for a sole provider earning less than $55,000 per year to cover the employee and their entire family. No cost for an employee only. And these rates would be good for the life of the contract. We think our proposal is modest and necessary, as the current benefits are unsustainable and are no longer aligned with the market and do not meet the financial limitations set by the Affordable Care Act. In fact, over the last 10 years, the average cost of health and welfare benefits per benefited employee at Washington Hospital has increased by 101%. This equates to approximately $18.3 million in an additional costs in fiscal year 2014. All such cost has been absorbed entirely by Washington and not passed on to our employees. Our benefits, unfortunately, are going to further increase by cost with the implementation of the Cadillac tax through the Affordable Care Act, and that's coming in 2018. Given this, along with all the other factors impacting us, we think our proposal is fair and reflective of our challenges. Because we've hit a critical juncture in our negotiations, we agree, pursuant to Resolution 331A, that a mediator should be brought in to work with both parties to bring this process to conclusion. We hope SEIU UHW Local 250 will be a partner with us as we adapt to the new economic realities that exist for all healthcare providers. Washington Hospital is a forward-thinking, financially sound healthcare system that continually works to adjust to the major changes in healthcare. We are not asking anyone to do anything more than is necessary so that we can all continue to fulfill our mission, which is to continue to provide the best possible care for the residents of our district.
Thank you, Nancy. At this point in the meeting, we normally have our oral communications from the public. I haven't received any
Cards?
speaker cards.
There.
We're anxious to be able to hear from any of the public that wish to speak, and we appreciate these speaker cards. I need to ask you, please, to limit your remarks to 3 minutes. Christine will be timing that. We need to do that in order for this meeting to end sometime this evening, and we appreciate your compliance with that. I also need to apologize if I mispronounce any of these names. I will make my very best attempt to do that, and I apologize if I mispronounce a name. We'd like first to hear from Nina. Nina, if you could give us your last name, that would be appreciated.
Good evening. My name's Nina Baniani, and I'm a respiratory therapist here at Washington Hospital. I've been employed here for 20 years, and I'm a proud member of the SEIU UHW. My coworkers and I have been very disappointed in the behavior of the administration at Washington recently, laying off long-time staff while still hiring per diems when current per diems are not getting hours, proposing cuts to the benefits of frontline caregivers. These actions have real impact on morale, which is an all-time low among employees. We hear you when the administration says that we are struggling, and we want to work with you and all hospital employers on reforming Medi-Cal and ensuring fair reimbursements. But we cannot focus on that important work when we need to protect our benefits. When we work together, great things can be accomplished. Let's get back to that. Thank you.
Second speaker will be Lanita.
Hi, my name is Lenitra Stevenson, and I am a Kaiser employee. I've been working there for 11 years, and I'm a proud member of SEIU UHW. I wanted to clear up any confusion that the district may have about employer-paid health care in our industry, ensuring that those who expose themselves to germs and bacteria of the hospital have free health care insurance is a standard that the hospital workers fought for decades for. And now it is an established practice, free health care for healthcare workers. Let me list just a few of the hospitals in the area that have premium-free insurance. Stanford Hospital, Regional Medical Center, Good Samaritan Hospital, Alameda Hospital, Eden Medical Center, Alto Bates Summit, all Kaiser facilities, O'Connor. I could go on, but you get the point. Free health care for healthcare workers is a standard, and we need to keep it there.
Our third speaker is Adelia.
Hello, my name is Adela Mendieta, and I've been working for EBS department for 26 years. I am proud a member of SEIU UHW. Washington Hospital for decades has been a destination workplace for healthcare workers. Management relations standards here were set that lift up the bar in the Bay Area. I choose to work here because of those high standards. The recent layoffs and cuts proposed to our benefit school changed that dramatically. We could be the least attractive hospital to work in the Bay Area. Washington could be dragging down standards not just for the employees who just cannot afford these cuts, but also for workers at other hospitals. The 480 SEUI UHW member at Washington Hospital will not let that happen. That 150,000 members of SEIU UHW across the state will not let that happen. Will we let that happen? And ultimately, I don't believe the community of the Tri-City area will let that happen. If the administration continues on this path of attempting to lower standards, expect a serious fight. Thank you.
Thank you. Our last speaker card is, I believe it's Michael. Is that true or not?
That's true.
Thank you. I just had a hard time reading it. I'm sorry, Michael.
No problem, no problem. Thanks for allowing me to speak for
If
a
you could
moment.
give us your last name.
Sure.
that'd be
My name is Michael Reeves, and I'm a phlebotomist here in the hospital. I've been here for just about 7 years or more, and I'm also a proud member of SEIU. I have here in my hand a report from the Benson Consultation Group, and they've conducted a survey of 500 registered voters in the Tri-City area, which is 500 of your constituents, in other words. And let me pass this to you. Who would like to take this? Thank you. We also have copies for the audience, and you can read it in detail later, but I wanted to highlight some of the key findings from the survey. These voters would overwhelmingly support a measure to cap compensations for district executives to that of the President of the United States, and they feel that the current executive compensation at Washington is unreasonable. Additionally, these voters support the Alameda County Grand Jury finding that term limits should be imposed on district board seats. We asked you in August, and with these findings we ask again, please place these issues of excessive executive compensation on the ballot for the voters to decide. If the board fails to act on this matter, voters may have to take matters into their own hands via the initiative process. In addition, I'd like to go off cuff just for a moment and say a couple things outside of the language of lawyers and accountants. In the arts of leadership, it's often said that those above don't eat while those below are hungry, and those above don't put on heavy blankets while those below are cold. And also that master carpenters could find a good use for every piece of wood. And so the practice of, or the layoffs as they've been coming down as trying to work with the ACA doesn't show the creativity necessary in the leadership to allow the workers to to fulfill themselves in their services to the community at this time. Thank you.
From Dr. Peter Lunny.
So I'm going to present the credentials actions items from September. We had 5 new physician applicants, medical staff applicants. 2 are non-physicians. The first is Sherry Armstrong, a perfusionist. The next is Rachel Miller, a physician assistant. Matthew Mufli, MD, anesthesia. Kuljit Multani, MD, family practice. And Tuao Ting, MD, surgery. For reappointments, Dr. Harry Andrews, medicine department, active. Dr. Megan Beatty, OBGYN department, active. Dr. Madeline Blaurock, medicine department, active. Dr. Remo Cerruti, pediatrician, ambulatory status. Dr. Brooke Cotter, medicine department, active. Dr. Anthony Dobson, OBGYN department, courtesy. Dr. Maggie Jones, medicine department, active. Dr. Uma Kantamununi, Medicine Department, active. Dr. Shakira Karapanini, OBGYN Department, ambulatory. Dr. Scott Keel, Family Medicine, ambulatory. Dr. Jennifer Lee, Medicine Department, active. Dr. Darlene Lee, Pediatrician, ambulatory. Dr. Terrence Lin, Medicine Department, active. Dr. Kelly Miller, Family Medicine, ambulatory. Dr. Michael Parmley, Medicine Department, active. Dr. Sabiha Rashid, Medicine Department, active. Dr. Sahota, Dentist, ambulatory. Dr. Henry Sanchez, Pediatrician, active. Dr. Nancy Salama, Family Medicine, ambulatory. Dr. Padmarja Sharma, OBGYN, active. Dr. Victoria Shimotsu, Family Medicine, active. Dr. Rona Silkus, Surgery, courtesy. Dr. Siddhartha Sinha, Medicine, active. Dr. James Song, Surgery, active. Dr. Rao Sankavalli, Surgery, active. Dr. Spencer Tilley, Family Medicine, active. Dr. Sabina Tilley, Family Medicine, active. Dr. Peter Tom, Medicine Department, active. Dr. Nally Singh, Medicine Department, ambulatory. Dr. Jennifer Wang, Medicine Department, ambulatory. And Dr. Emily Liu, Family Medicine, ambulatory. Non-reappointments deemed to have resigned: Fang Gao, Registered Nurse, First Assist. Transfers in staff category, we have Dr. Spencer Tilley and Dr. Sabina Tilley in Family Medicine moving from active to ambulatory status. And then resignations, Dr. Edward Cohen, OBGYN, Dr. Andreas Kamlot, cardiovascular, Yvonne Moreau, physician assistant, and Dr. Richard Nguyen, general surgery. Dr. Robert Peralta, ophthalmology, and Dr. Grace Yu, pediatrics.
Thank you. I'll entertain a motion on that.
Mr. President, I move for approval of credentialing action items as presented.
Second. We have a motion and a second. Any discussion? Christine, please take the roll.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Eapen.
Aye. Thank you. That motion passes. We'll now have our Service League report from Gail Tomita. Gail, it's nice to have you with us again.
On Thursday, October 16th, the East Bay Council of Hospital Volunteers will hold a speakers meeting with speakers Lily Stamets from UC San Francisco, manager, the gift shop at UCSF Medical Center in San Francisco, and Marianne Jones from Redwood City, patient experience and hospital concierge at Sequoia Hospital. They will be speaking on the power of people. The meeting will be held at the Fellowship Hall at Hillcrest Congregational Church in Pleasant Hill. Registration is at 9:30 and speakers are scheduled from 10 to 11:30. Joan Cardellino, the California Hospital Director of Volunteer Services, will be giving an update also on what is happening in California. California is very fortunate. It's the only state to have such a director, and she really keeps us informed on medical issues in the state of California. On November 6th and 7th, the gift shop will be having their holiday gift show, and there'll be music, cookies, coffee, and a chance to enter the drawing. They always have beautiful items that they give away, so hopefully everyone will come. On the 6th, they will open at 7 a.m., and there's a 10% discount if you come and shop early. Every day they'll be there from 7 a.m. all day to 4 p.m., so please come by the gift shop and see what's going to happen for the holidays. That's it.
Thank you, Gail. I just put a plug in for the jewelry sale. The gift shop sale. That's a
No, it's
great.
a gift shop
The
sale.
gift shop sale, I'm sorry.
Right.
This is a great, great event. Wonderful items.
Well, the gift shop really decorates for Christmas and the holidays, so they always do a great job. They're having a great sale on Halloween items, so if anybody is interested, they still are available.
And a lot of things look interesting.
They've been doing a very good job.
Thank you for your work there, and thank you for the opportunity to go to the sale in November. Thank you. Medical staff report from Dr. Lunny.
Okay, our current medical staff is comprised of 543 members, 330 of whom are active, 86 provisional, 67 ambulatory, 3 administrative, 30 courtesy, and 24 allied health professionals. And we're down to 13 applications in process right now. So.
Cutting that down.
Cutting that down, yeah.
Thank you. Thank you for that report. We'll now have our hospital calendar report. Nancy, if you could do that.
Past health promotions and outreach events. On Monday, September 15th, 22nd, and 29th, Dr. Victoria Leapart, gynecologist, presented the remaining 3 sessions of the Restoring Balance program, a 4-week stress reduction program. 20 people attended. On Tuesday, September 16th, Dr. Jason Van Tassel, ear, nose, and throat specialist, presented relief from sinus issues. 15 people attended. On Wednesday, September 17th, as part of the Healthy Knowledge at Noon series, Dr. Vandana Sharma, oncologist, presented Lifestyle and Cancer. What can you do to reduce your risk? 11 people attended. On Monday, September 22nd, Lucy Hernandez, Community Outreach Coordinator, provided bone density screenings for osteoporosis for employees at Boehringer Ingelheim, located in Fremont. Boehringer Ingelheim is a pharmaceutical manufacturing company. 47 employees were screened. On Wednesday, September 24th, the Community Health Resource Library participated in the Health and Safety Fair hosted by Carlton Plaza of Fremont. Staff provided bone density screenings for osteoporosis. 26 people were screened for osteoporosis and 85 people attended the event. On Saturday, September 27th, Washington Hospital staffed an information booth at the HERS Breast Cancer Foundation Keep Abreast 5 and 10K Walk Run event at Quarry Lakes in Fremont. The event raised funds for breast cancer programs and services. Washington Hospital was a sponsor. Over 600 people participated in the event. On Wednesday, October 1st and 7th, Christy Caracappa, Health Insurance Information Service Coordinator, presented Medicare updates for 2015. Both of these seminars provided information for Medicare enrollees on changes and updates to Medicare plans for the coming year. Over 20 people attended. On October 1st and 3rd, Lucy Hernandez, Community Outreach Coordinator, presented hand-washing classes at Vallejo Mill Elementary and Mission Valley Elementary School in Fremont and Kennedy Elementary School in Newark. Information was provided on proper hand-washing and hygiene to prevent infection and the spread of germs. 81 students attended. Also on Wednesday, October 1st, the Washington Hospital Lab, along with Washington Township Medical Foundation, participated in the City of Fremont Health Fair. The lab provided cholesterol and glucose screenings, and WTMF provided blood pressure screenings. 74 people were screened, and 150 people attended the event. On Thursday, October 2nd, as part of the Diabetes Matters series, Michelle Heading, RN, and Diana Jaycox, RN, presented CDE, When You Care Too Much, giving the right kind of support to a loved one who has diabetes. 12 people attended. On Sunday, October 5th, Washington Hospital staff participated in the Tri-City Area Rotary Club's annual Rotary Chili Cook-Off. The event raised money for local charitable organizations, including Tri-City Rotary Clinic, Life Elder Care, Washington on Wheels Mobile Health Clinic, and the Hope Project Mobile Clinic. Over 300 people attended. On Tuesday, October 7th, Washington Hospital participated in the City of Newark 15th Annual Senior Resource Fair at the Silliman Activity Center. Staff provided bone density screenings for osteoporosis. 26 people were screened for osteoporosis, and over 200 people attended the event. Also on Tuesday, October 7th, Christy Caracappa, Health Insurance Information Service Coordinator, presented Medicare Part D prescription drug coverage. 17 people attended. Upcoming health promotions and community outreach events. On Friday, October 10th, Lincoln Elementary School in Newark will hold a walkathon. Washington Township Medical Foundation will staff a booth and provide health information for students, teachers, and parents. On Tuesday, October 14th, from 5 to 7:30 p.m., Washington Hospital will host the annual Think Pink Breast Health Awareness event. The event will feature a health fair and presentations by Dr. William Degoni Jr., surgeon, Dr. Mimi Lin, radiologist, Dr. Vandana Sharma, oncologist, and Kimberly Alvari, registered dietitian. On November 14th, from 2:30 to 3:30 p.m., Dr. Alexander Saw, orthopedic surgeon, will be presenting treatments for hip pain. The Washington Hospital Healthcare Foundation report. On October 11th, the Washington Hospital Healthcare Foundation will host the 28th annual Top Hat Dinner Dance. This year's gala will be co-chaired by Rod Silvera and Skip Turner, the owners of Professional Home Care Associates and Neurosport, and Dr. Jan Hensdorf, Chief Medical Information Officer at Washington Hospital. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the Washington Special Care Nursery, which is affiliated with UCSF Benioff Children's Hospital, San Francisco. This unit in the hospital cares for babies born prematurely or with life-threatening conditions. Funds from the gala will support patients' families and provide technology upgrades. The event is sold out. However, it is not too late to purchase raffle tickets. The winner of this year's grand raffle will receive a cash prize of $2,400. To purchase raffle tickets, please call the foundation at 510-791-3428. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District Board members attended the 12th Annual Save Breakfast Eye-Opener on September 26th. the Union City Chamber of Commerce State of the City Luncheon on September 30th, and the 23rd Annual Rotary Chili Cook-Off on October 5th. Washington on Wheels WOW Mobile Health Clinic. During the month of September, Washington on Wheels Mobile Health Clinic WOW continued to serve community members at the Fremont Family Resource Center, Fremont Senior Center, the Silliman Activity Center in Newark, and the New Haven Adult School and Rogeri Senior Center, both located in Union City. WOW also provided healthcare services to students at Briar Elementary School in Fremont. WOW also provided occupational health services, including influenza vaccines, to Plexus, a leading electronic manufacturing company in Fremont, and Emerald Packaging, one of the largest packaging manufacturers on the West Coast in Union City. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of September was 338. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was September's most viewed webpage. InHealth, Channel 78. During the month of September, Washington Hospital's cable channel 78, InHealth, taped new programming, including the Diabetes Matters program, The Diabetes Domino Effect, and a health and wellness seminar, Relief from Sinus Issues. InHealth aired new programming, including prostate health and prostate cancer, GERD, and your risk for esophageal cancer. The Washington Hospital Experience, Sandy Amos RN Infusion Center, and the September Board of Directors meeting. Awards and recognitions. Alex O'Brien, RN, was recently presented with the DAISY Award for Extraordinary Nurses. DAISY is an acronym for Diseases Attacking the Immune System, and the award was established by the family of J. Patrick Barnes, who died of idiopathic thrombocytopenic purpura. His family established the award to honor the excellent work that nurses do every day at the bedside. A staff nurse on 5 West, Alex was recognized for her commitment to patient care. She is regarded by her peers for excellence and leadership on her unit, and for caring and always practicing the magnet and professional practice models. Alex exemplifies the patient-first ethic in everything she does, says Sam Avila, RN, nurse manager of 5 West, Institute for Joint Restoration and Research, and CSU and New Grad Program, by constantly demonstrating compassion, kindness, sensitivity, and being a clinically competent provider. She is a perfect example of a nurse practicing the magnet model. Washington Hospital is the recipient of CalNOC's 2014 Performance Excellence in the Prevention of Hospital-Acquired Pressure Ulcers. The hospital was recognized by CalNOC, also known as the Collaborative Alliance for Nursing Outcomes, for the excellent work and better-than-expected performance in its prevention efforts. Always on the forefront of patient care excellence, CalNOC created the first nursing database registry of nursing-sensitive indicators, which turns patient outcome data into powerful information for hospitals to help guide decisions to advanced global patient care. Today, CalNOC is the nation's only nurse-sensitive registry managed, operated, and designed by nursing. Hundreds of leading hospitals have joined CalNOC to monitor and benchmark performance in order to deliver excellence in patient care. Other updates. The flu vaccine continues to be available throughout the remainder of the flu season while supplies last from 8 a.m. to 8 p.m. 7 days a week at Washington Urgent Care. Appointments are not necessary. Washington Urgent Care accepts most insurance plans or will administer the vaccine for those who want to pay cash. Washington Urgent Care is located at 2500 Maury Avenue, Washington West Building, 2nd floor. For more information, call 510-791-CARE or visit whhs.com/urgentcare. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
Before I announce our Employee of the Month, there were a few other announcements I wanted to make. Joe, would you put that photograph up on the screen? Can you do that for me? I'm going to ask you, why is this man smiling? I think you all know Robert Alfieri. We were pleased recently to receive a $40,000 check from PG&E as a result of participating in the utility's Energy Incentive Program. The program consists of PG&E performing a baseline evaluation of our facility, followed by the development energy efficiency recommendations. Based on implementing one of their recommendations, the hospital qualified for a $40,000 reimbursement check from PG&E. In addition to the rebate, the hospital will also realize significant ongoing energy reduction of 740,000 kilowatt hours, which equates to savings of about $75,000 a year. So I think Robert is to be congratulated, and it's readily understandable why this man's smiling. The next bit of news is perhaps not as much fun. The Department of Health Care Services wants to notify all California Medi-Cal providers of recovery audit contractor program being implemented. This means the RAC audits will apply to all Medi-Cal patients. They have contracted with a company called Health Management Systems Incorporated to act as the RAC for the state of California. They will perform desk and field audits for selected fee-for-service Medicaid claims paid within the last 3 years, which means they're going to go back 3 years and start taking money away. They will contact the providers whose claims have been selected for review, and after the initial contact, providers may receive letters from HMS requesting medical records for further review. The Department of Health Care Services urges all providers to treat HMS in the same manner as the Department of Health Care Services or any other government or law enforcement agency. Providers are told they need to furnish accurate and complete contact information and access to medical records. Failure to comply with the medical records requests will be considered an error and may result in overpayment recoupment. Providers can submit medical records documentation to HMS via secure fax, mail, or encrypted media. So what has been plaguing us with Medicare is now being extended to Medi-Cal. And to a much more pleasant subject, I want to introduce you to Jocelyn Love. She's a staff nurse 3 on 6 West, and she's our October Employee of the Month. She is described as a very positive spirit who loves Washington Hospital. She came to Washington Hospital as a new nursing graduate. She successfully completed the new grad program and continues to work on 6 West. She does whatever it takes to get the job done and to provide excellent patient care. She has a big influence on 6 West and on their professional practice. She works an extremely busy shift that supports night and days on 6 West. She is the spine program coordinator and interfaces with the spine patients and their physicians. She's married to her loving husband and has 2 kids in school, and she's incredibly proud of them and their achievements. She's a staff nurse 3 who demonstrates flexibility and accountability, and she places phone calls to the discharged patients of 6 West to ensure their discharge went well and that they will be following up with their doctor. She helps improve the patient experience on 6 West by problem solving, taking admissions, and welcoming the patients. She graduated from Cal State East Bay in 2001 and has helped to mentor many new grads. And we think she's a very deserving Employee of the Month. Very proud to honor her in this way. Okay. And I would advise the board there is no construction update for this month.
Thank you. And we can move immediately to our quality report and hear from Mary Boron. Mary?
Good evening. I wanted to spend a little bit of time talking to you about our Meaningful Use reporting program. Meaningful Use is a program that was implemented by the Centers for Medicare and Medicaid. It was implemented really with the idea of how can you take your electronic medical record and use it to your advantage to abstract data, use it to improve healthcare outcomes. So when they implemented the program, they tried to implement like incentives for hospitals that if you can have an electronic medical record in time, you could receive incentives and use the data to better impact patient care. Some examples of the things that they want to focus on are preventing readmissions, ensuring that medications such as aspirin and statins are prescribed at discharge. You hear us talk a lot about that with core measures. Meaningful Use also wants to look at this. And providing safe and efficient access to healthcare information online for patients. So the program overview, again, just focuses on improving outcomes for patients that are really quality driven. The first part is assuring that every hospital has an electronic healthcare record implemented. And 5 of the goals that they've chosen to focus on is, making sure that the care that we give our patients is safe, efficient, and reduces disparities. Also, really, there is a focus on improving communication between patients and their caregivers, making them have better access to their medical records, and really encouraging care coordination, which is really with us working with patients in every transition of their care in the hospital and communicating and letting them know what type of care they're getting as early as possible and helping them transition after they leave the hospital into home care or to following up with doctor's appointments, that sort of thing. They also want to assure that we're providing adequate safety with regard to privacy of the patient's medical record. So CMS has agreed to implement this into 3 phases. The first stage is really making sure that we can capture the data that they're looking for us to provide to them and making sure that the clinical processes are being done correctly and providing care to patients. And then the third phase is how can we use this data to implement and provide better patient outcomes. They want to also focus to make sure that the measures are objective and just focused on quality. So how did we get here with Meaningful Use? The history behind it is that in 2009, it was suggested by a national goal by the American Reinvestment and Recovery Act that really focused on improving the economy and technology in the United States. They came up with this program of using Meaningful Use. So in 2010, CMS published this rule and stated that this was something that they wanted hospitals to partake in. In 2011, the incentives started, that are broken up into stages. And stage 1 was a voluntary participation in which you would provide 90 days of data from that year. So bringing us forward to this year, 2014, they have extended some deadlines with when people can have their EMRs implemented. And when we have to report what the quality measures are that we're looking for. But for the most part, moving into 2015, the participation will be mandatory at that point, and CMS will begin to implement payment adjustments according to how far you are in your Meaningful Use process as far as the participation goes. And there could even be a 1% Medicare payment reduction for the first year, and this reduction could end up going up to about 5%. So they've set it up in a way that you really should participate. It benefits you financially and just really teaches you how to use the medical record to your advantage. In 2016, they will no longer provide incentives for this. They will expect hospitals to be up and running with Meaningful Use, and it will be required. So the stages that we're looking at really go into about 3 different stages. The first stage is, do you have your electronic healthcare record implemented? And are you capable of gathering data from it and reporting it out? And they really, in the first part, are just looking at you to report about 6 of the 44 required measures. Meaningful use stage 2 takes it a step further. Can you collect the data and use it to help you focus on improving your care coordination? Can you engage the patient in utilizing the EMR to their advantage, like giving them access to look at things like MyChart, that sort of thing? And they've also set the goals higher for when you move into stage 2. And then for stage 3, the CMS really has this still under development, but it will be focused on what are you doing with the data to improve your quality outcomes. The details of that have yet to be presented by CMS. So where are we at specifically with Washington Hospital right now is really the next question. We began to plan for this in fall of 2012, and we, as you know, were able to implement our EMR in July of 2013, so we were able to be compliant with that requirement and received incentive payment for it for fiscal year 2013, which was a total of about $1.2 million. So stage 1 and year 1 data was submitted this year at the end of June 25th in 2014. And we also were able to receive further incentive payment for being compliant at this far. So to date, we have about $2.7 million in incentive that we've received by participating exactly where meaningful use expects us to be. And stage 1, year 2 data was actually submitted recently at the beginning of this month, October 1st. So currently, we want to focus on moving into stage 2 and further complying with what CMS is expecting at this point. This is just some example of things that they're looking at. When I talk about the data of what they're looking at, they want to make sure that you can collect your patient demographic, which we've been able to do with our EMR. Can you monitor the vital signs, growth charts, things like that have come pretty simply for us. You can see we're at the 94% compliance with the 90 days of data that they looked at. Do you have an active problem list in your EMR, which we do, and we've complied well with that at about 100%. Active medication list is something that we've really focused on, making sure that it's accurate and it's up to date and that it's actively being used. We have a compliance rate of about 100% for that. The goal was 80%. Making sure that you have all of your patient allergies listed in the EMR. They're visible and easy to look at and see for the healthcare workers. Done really well with that. We're at about 100% compliance. And capturing smoking status in your patients. They expected about a 50% goal there. We were able to reach it at 96%. And making sure that our computerized medication orders are done appropriately. And they expected about a goal of as low as 30%, but luckily we were able to reach 84% for that. And as I mentioned before, engaging patients and being active in accessing their electronic medical information has been a focus on this because they want them to be as aware as they can about, how did the lab results turn out? It helps them look through their medical record and decide and prepare for visits and conversations with physicians so that they know what questions to ask and that they're as aware they can be about their current health status. We've done really well at that, about 95 or 97%. Further focus on stage 1, year 2 is engaging the patients to make sure that you address the issue of the advance directive with them. We've done really well with that at 100%. They were expecting more like about 50%. Are the lab tests available in the electronic record? Yes, 100% of the time we were able to abstract and pull that they did that. And the medication check for care transitions. So do they have the right, most accurate set of medications when they leave here and when they're discharged? 96% compliance rate. So we've achieved that goal by almost double. CMS was expected us to be at about 50%. And do they have the education resources that are specific to what they came in here for? Did we give appropriate discharge instructions? Did we prepare them for signs and symptoms to watch for that may lead for them to have to come back or call their doctor? That goal also was met at about 100%. So moving in the next directions with meaningful use will really involve us to continue to plan and review our stage 2 measures, which become more extensive with each stage that you progress to. And taking those measures and learning for how we have opportunities to improve, which is the whole point of meaningful use. So when we abstract the data and look at it, how can we use it to identify opportunities that we can improve in? And moving into submitting the required data for 2015, so we're on target for being able to do that. And in having done that, we would also like to move towards gaining our maximum CMS incentive to reach our goal. And that's it. Any questions?
Thank you, Mary.
Thank you.
That's an encouraging report.
It is, yeah, we're doing well with
Yeah,
it, so.
that's very, very nice to see.
Thank you.
Always, government always has a big stick behind
They do, yeah.
all
That's
these things.
At
but
least
it's-
this one's coming with a little bit of incentive, but 2016, got to be ready to go and fully participating, which it looks like we're going to be able to do that.
Very nice, thank you.
Yeah, thank you.
Any other comments from the board?
Thanks.
Thank you again, Mary. We'll now have our finance report from Chris Henry.
Thanks, Dr. Stewart. Tonight we'll be reviewing the operational and financial results for Washington Hospital for August 2014. We'll move right into our statistics. Average daily census for the month came in at 129. We'd expected 146. Our admissions were 4 above budget at 435. Our patient days came in 523 below budget at 4,003. Outpatient observation days for the month came in 33 above the budget at 278. And our average length of stay for August was 4.13. We had expected 4.86. So we had lots of admissions, shorter lengths of stay in the month. Case mix index for the month, not surprisingly, 1.431. Our deliveries for August were higher than we've seen in a long time, 18 above the budget at 183. We had 341 surgical cases in August, 2 just below the budget. That includes our joint replacement cases that were 2 above budget at 107. Our neurosurgical cases were 2 below budget at 23. And our cardiac surgical cases for the month came in at 6. We'd expected 9 for August. Cath lab procedures for the month came in pretty close to budget at 599, just 17 below budget. Our outpatient visits were 557 below the budget at 7,047. The emergency room, however, seems to be getting busier as we move through the year. They had 397 more visits than we expected for August at 4,371. A quick look at our cath lab activity. Not a lot of change in the mix here. Again, vascular, peripheral vascular, and cardiac lead the way with the percentage of volume, followed by non-vascular and neuroradiology. Looking at productivity, our productive FTEs for August came in 12 below budget at 1,109. We had 202.5 non-productive FTEs, giving us total FTEs for August 10.5 below the budget at 1,311.7. Our FTEs per adjusted occupied bed, which is our productivity measure, came in above the budget at 7.06. We were having some extra folks here. Again, this was getting ready for Joint Commission to show up, so we had some extra folks on hand to get that going. Moving into the financials, gross patient revenue for the month came in 4.1% below the budget at $153,339,000. Our contractual reserves for the month were lower than budget at 75.76. Of note, we did have a big increase in PPO in August at a little bit over 25% of the total gross revenue. We've been running between 19 and 20% over the last year, so big jump there. And I think we saw that continue in September to some extent, so some good movement there. So we ended August with net operating revenue about 3% below budget at $37,332,000. Our operating expenses came in 3.3% below budget at $37,134,000. Big drivers there were our benefits with lower health and welfare claims incurred during the month. Supplies were below budget with our lower patient census, and our reserves for bad debt and charity were lower than expected with the lower level of revenue. So we end the month with an operating bottom line just under $200,000 for August. Non-operating income for the month came in at $1.254 million. That included an unrealized gain in our investments of $173,000, giving us a total bottom line about $317,000 above budget at $1,452,000. Quick look at our FASB presentation. This is some adjustments we make to represent how the financial markets might look at us as opposed to the Governmental Accounting Standards Board. Our operating bottom line stays the same at $198,000. We remove our tax revenue that supports the service of our general obligation bonds and our unrealized gain on our investments to come up with a non-operating income from a FASB perspective about $21,000 above the budget at $297,000 and a total bottom line of just under $500,000, $144,000 above the budget. So are there any questions on August results?
Nothing from the board. Thank you. Then we can move on to our operations report.
This is the preliminary report for September. We saw 1,026 patient admissions. They resulted in an average daily census of 148, 7.8% higher than the budget. The average daily census recorded in September of last year was 150, by way of comparison. The high and low census ranged from 168 down to 125. Outpatient observation equivalent days of 258 were higher than the budget we had planned on 242. The average length of stay for adults and children in September was lower than budget at 4.06. This is lower than August's average length of stay, which was 4.13, and the budget had anticipated an average length of stay of 4.86. The birthing center saw 163 deliveries in September, compared to the budget of 148. Our deliveries resulted in 361 baby days of care. Our newborns totaled 168, so we had some twins in there. By comparison, a year ago, we had 146 deliveries. For the month of September, we had 362 surgical cases, 15 above budget. This included cardiac surgical cases that came in 1 above the budget, neurosurgical cases that were 5 above budget, and joint replacement cases that came in 1 above budget. All general surgery cases were above budget by 8. Inpatient surgical activity was below budget by 29, while outpatient surgeries were above budget by 44, or a 78.6% positive variance. Total surgical minutes were above budget by 594. That's a 1.3% factor. Our inpatient surgical minutes were below budget by 9.3%, and the outpatient surgical minutes were 80.6% more than expected. A lot more outpatient volume. 660 cases were seen at the outpatient surgery center. They had budgeted for 584. So they were seeing more business as well. For the month of September, the total procedures seen in the cath lab were 738. We had budgeted for 527. Our overall cath lab volume for September of 2013 by comparison was 587 procedures. Our cardiac procedures were 46.2% of the budget, or 55 cases. And peripheral vascular procedures were 54.8% above budget by 80 cases. Neurointervention procedures were 1 case above budget. Non-vascular and other procedures came in at 75 cases, or 30.4% positive variance. Overall, cath lab procedures were 140 more than anticipated for a positive variance of 53.4%. Outpatient procedures were 71 more than expected, for a 26.8% positive variance. Non-emergency outpatient visits. They totaled in September 7,137. They were 1.9% lower than the budget of 7,276. The emergency room recorded a total of 4,586 patients, with the daily average of 153. This was a 7.7% positive variance, or 328 more patients than we had budgeted. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 4,060 patients during September. That's 787 more patients than we had budgeted. So total system emergency room and clinic visits for September are 8,646 compared to a budget of 7,531 visits. In terms of full-time equivalents for the month of September, we had 1,337.8, including 18.6 agency personnel, the predominantly associated with IT. This came in at 0.5 higher than the budget. Productive FTEs per adjusted occupied bed were 5.63 in September, which was below the budget. Total FTEs per adjusted occupied bed were in at 6.5, which was also below budget. Productive FTEs were below budget by 10.3 for the month. Non-productive FTEs came in at 10.8 FTEs above budget. In terms of patient mix, our preliminary information indicates that inpatient revenue for the month of September amounted to approximately $120.4 million compared to a budgeted estimate of $120.7 million. Of this amount, 51.7% was Medicare, including Medicare HMO, and 21.7% was Medi-Cal, including the Medi-Cal HMO patients. This compares with the budgeted inpatient revenue percentages of 57.6% Medicare and 16.7% Medi-Cal sponsored patients. We had more than budgeted in Medi-Cal. The total government program revenue for September was 73.4% of total inpatient revenue, and we had budgeted for 74.3%. That's right on the nose. Based on September's 4,432 patient days, 55.6% were Medicare, including Medicare HMO, and 18.9% were Medi-Cal, including Medi-Cal HMO. We just went over that. I'm sorry, I'm repeating it. I apologize. In terms of revenue, let's talk about money. We came in under budget by $300,000, or 0.3%. The outpatient revenue for September was above budget by $8.4 million, or 21.6%. It's a good variance to have. The inpatient revenue variance is due to lower census, which drove lower utilization of ancillary services. Outpatient revenue was higher than budget due to increased activity in the operating room, the cath lab, and the emergency room. In summary, we had 74 more admissions and 193 less inpatient days than anticipated in the budget. Our surgical cases were above budget by 15. Cath lab procedures were above budget by 211 for the month of September. Outpatient visits were 139 below budget, and ER visits were 328 higher than anticipated. Clinic visits for the month were above budget by 787. Total paid FTEs were slightly above budget by 0.5. Inpatient charges for the month were slightly below budget by approximately 0.3%. Outpatient charges were higher than budget by approximately 21.6%. Total hospital charges for September were above budget by approximately $8.1 million, or a 5.1% positive variance. On September 30th, there were 164 days cash on hand. The total days revenue and accounts receivable at September 30th was 69.9. The days revenue and accounts receivable excluding Medi-Cal was 68.6. Days in accounts receivable excluding the Alameda Alliance, which is in receivership, was 54.9. Bulk of the difference in where we'd like to be is associated with that relationship. During the month of September, $678,437 of charges were approved or are pending for charity assistance, again reflecting the shift from straight charity to Medi-Cal.
Thank you, Nancy. Encouraging September.
Yes, it is.
Thank you very much. We'll now move to our final action item of the evening. We've considered item A already. Dr. Eatman, if you could present item B.
Mr. President, I move for the adoption of resolution number 1149. This is a resolution to provide for the implementation of the permanent improvements to Civic Center Drive to include a traffic light project for an amount not to exceed $1,864,377. In accordance with the district law policies and procedures, I move to approve this project to include the authorization for completion of construction documents by the hospital civil engineer and authorization by the Secretary of the Board of Directors to publicly advertise for firms to pre-qualify to bid on this project.
Second.
We have a motion and a second on this item. This is a unusual and extensive item, and we're going to look to an extensive discussion of the item so that the public and all members of the hospital can be totally aware of this. Nancy, if you could...
I'm going to ask Mr. Fayan to take point on this discussion. He has a number of people here to present.
Great. Ed, thank you very much.
Thank you, Dr. Stewart. So I wanted to talk a little bit about the crosswalk and the traffic light that we're recommending that we implement here in the immediate future. First, I would want to say that back in April of this year, we did make a variety of improvements to the crosswalk area, and actually the city of Fremont made them at their cost. And they included the planters going out there and strobe lights being placed on the crosswalk that both were, I think, significant improvements, and I think both made the crosswalk safer. And for 6 months, we have not had, knock on wood, any accidents out on the crosswalk. I would say there's a few things that I would like to say about that is that, number one, we are going into outside of daylight savings here in the next 30 days, so it's going to become a little bit more of a dangerous area again, the crosswalk, because of the lighting. Also, we're going into inclement weather, and when that happens, and some of the accidents that we have had out there have been during inclement weather, and it makes it a little bit more dangerous. And finally, to remind everybody that under the current circumstances, we do not, as pedestrians, have a right-of-way on that crosswalk. We have some certain protections out there, but it is still the vehicles that have the right-of-way. And sort of to demonstrate that, I just asked for our security department to just cull out a few close calls that we've had. I asked them to do it last week, and I've made a quick video, but you can kind of see what I'm talking about in terms of who has the right of way. So this is relatively short. Okay? You'll see this is sort of like running the gauntlet, that you've got some close calls, people coming. You also notice that the crosswalk is extremely busy, much busier than you would think, particularly in the morning hours, but a lot of traffic. I think this is one where she gets close to the end, and then you'll see at the end, it's a close call. This next one is our security officers coming across, and you'll see it's a good thing they were paying attention. So here's the driver isn't quite sure what to do. That was in there to show that the security guards pointed out that once somebody's in the crosswalk, they're supposed to be, traffic is supposed to stop. Even though they don't have the right of way, once they're in the middle, it should be, people should be paying attention. There's one where she started and was then had to stop. Sort of taking your life in your own hands as you walk through, as you can see sometimes. And this one has a bicyclist as well as a nurse coming across, as I recall. Here he comes. So we have a few speakers to talk to the traffic light and the crosswalk situation. First is from our traffic consultants, TJKM. The board in the past has heard from one of the engineers by the name of Chris Kinzel. Tonight we have Nyan Amin, who is the president of TJKM Transportation Consultants, with more than 20 years of professional experience in the public and private sectors, with extensive experience in transportation planning, traffic engineering, traffic operations, transportation design, traffic signal systems design and operation, and intelligent transportation systems planning, design, and construction support. Mr. Mean.
Thanks, Ed. Good evening, everyone. Couple of things as we noticed on the video, that it's a confusion going on at the intersection or at the mid-block crosswalk, as we call it. Who has the right of way? We need to define it. We saw a lot of close misses. And it's going to happen because the pedestrian, when you have a mid-block crosswalk, they're going to think they have the right of way. If they start walking into the crosswalk, the drivers have to yield to them. Is it in reality going to happen? Maybe the answer is no. The vehicular driver is going to think, I'm already on the road, the pedestrian stepped in, I'm going to try to cross them or cross the crosswalk before they are right in front of me. And sometimes judgment error happens. Not only that, the location where we have the crosswalk is not one of those standard ones where we can go and evaluate from traffic as well as pedestrian volumes and clearly identify that a traffic signal is needed. Nowadays, with the initiative going on for complete streets throughout the state of California and throughout the United States, trying to make pedestrian and bicycle friendly street or roadways, we are seeing a lot of mid-block crosswalks or locations where traffic signal warrants are not met. And this one would be one of the locations with a heavy pedestrian traffic against a high-speed roadway or a vehicular traffic. It would be the best location to improve the safety for the pedestrians between the two campuses or on either side of the roadway, the Washington Hospital campus, to have a traffic signal. Couple of months ago, City of Fremont hired a consultant to have an independent review. And based on the study and the analysis what they performed, one of the recommendations they suggested that installation of a full traffic signal should be considered if the hospital want to proceed with this type of traffic control devices to make it much safer for the pedestrians. And based on the work, what we have been helping out the team on making this crosswalk to be safer, that was one of our recommendations too earlier, that maybe a traffic signal should be considered at these locations. Installing a traffic signal at the location, is it going to have any impacts on the emergency vehicles? We don't anticipate that, because nowadays with the sophisticated controllers and the emergency vehicle preempt, what would be embedded into the system, whenever there is going to be an emergency vehicle approaching the emergency room, the signals would turn green for the emergency vehicles to make that movement. So we don't see it from the emergency response time, any impact having a traffic signal at this location. With that, I think if there are any specific questions I can answer.
It appears we have none. We appreciate your report, though.
Okay, thank you.
I thought it might be helpful to also go over the construction plan very quickly, and for that, we have two folks here from Kieran Wright, our civil engineers. Steve Calcano is the principal in the Pleasanton office that's here, but we're going to have a presentation from Garrett Riedler, who's been intimately involved with this. Garrett is a civil engineer with 9 years of experience, and he's been associated with the firm since 2005. He's well diversified in design and coordination of both on-site and off-site improvement projects. And his experience has been in both private and public sectors, which includes street improvements, road widening, warehousing and office buildings, schools and community public parks, citywide improvements of public sidewalks and driveways to meet ADA and retail projects. Garrett?
Hi, my name is Garrett Riedler. I'm with Kieran Wright. What you're looking at here is the full signing and striping plan from Mallory Avenue to Bart Way, where the improvements are going to take place. And what what these improvements are showing is the permanent permanent improvements on Civic Center, and which include full curb gutter sidewalk that would replace the existing asphalt curb that you see in the temporary condition. Starting at Mallory Avenue, the improvements that'll occur at that traffic signal are the removal of the kind of what we call pork chop islands and modifications to the traffic signal. What that will do is now traffic headed northbound on Mallory Avenue will have to go now through the signal. They won't be able to make that right-hand turn at a higher speed. They'll make a hard right turn, slowing them down as they approach the crosswalk. What this will also do is now keep Civic Center Drive a one-lane road in each direction towards Bart Way and towards Mallory Avenue with parallel parking on each side. The sidewalks that will be created now will be 16-foot wide sidewalks with trees spaced at 35 feet on center, creating more of a boulevard and aesthetic effect as you're walking down the hospital property. At the mid-block crossing, as TJ Cam discussed, there will be a new traffic signal fully controlling that crossing between pedestrians, requiring all traffic to stop as pedestrians cross. And at Bart Way, we'll be modifying that intersection as well with signal modifications similar to the Mallory Avenue improvements. You have the.
We have just a couple of shots here.
So this is what it looks like now facing Mallory Avenue, the current condition. And we had a photo rendering done of what the condition will be following the improvements. So you can see the new trees. This is showing the trees at a 5 to 10 year maturity level. The wider sidewalks, the new signals with the lights casting down. The sidewalk or the crossing will still look the same in the sense that you'll have the enhanced red paver look. You'll have new ADA ramps going across the street, and you'll still have the left turn into Washington West and into the main hospital controlled by the signal. And if there's any technical questions, I'd be happy to answer them.
When a car is waiting to do the left hand into Civic Center, that stops all traffic behind them because there's just one lane. Is that true?
No, there will be dedicated left turns into Washington West and to the main hospital property.
Okay.
That's different from, you may remember that it's blocked off currently, but in the new, it'll be open back up in the new arrangement.
I see a dedicated lane as normal turn is. Thank you.
Correct.
It looks a lot cleaner
Mhm.
this way, a lot less confusing. The street right now is just, I can see it on the drivers, and I've experienced myself. You don't know which lane to be in. It's just way too confusing. But I have a question. When you're approaching Mallory, you can turn right or you can turn left. Will a U-turn be allowed?
I believe the U-turn will still be allowed at Mallory back down to Civic Center Drive. There will still be adequate room to make that movement.
So, okay, without the pork chop
Correct.
cutout right there, there will be sufficient room for people to do a U-turn.
Correct.
Because there's a lot of traffic in that area as well. Foot traffic. Okay, thank you.
Okay, thank you. So this is a fairly significant project. We have a total budget of $1.8 million, and that includes putting in new traffic lights. Obviously, at the crosswalk is the main one, and then we're making changes at the two streets that are at the either end of the hospital campus, and it includes curb, gutter, sidewalk, all those things, and that's our project. Any questions that I can answer?
Do we, at this point, I'd open this discussion to the public. If there be any of the public that want to comment on this, we'd be anxious to hear. I see Rod Silvera moving. We appreciate him being here, appreciate his willingness to come and speak to the issue.
I am the Vice President of the Washington Hospital Healthcare Foundation, and more importantly than that, I am the a Top Hat co-chair of the Top Hat 28, so I just want to share that with you all. Hopefully, we'll all be there on Saturday. The letter is from the foundation officers, and it's directed to Dr. Stewart. We are writing today to express our support for the decision of the Board of Directors, Washington Hospital Healthcare District, to apply to the City of Fremont for permission to install a traffic light on Civic Center Drive, where the driveways from the Emergency Department and Washington West intersect. In our view, even with the improvements made to the street and the narrowing of the road to one lane in each direction, this is still a dangerous intersection that presents a confusing scenario to drivers and still leaves pedestrians vulnerable to distracted motorists. Clearly, the narrowing of the road to one lane in each direction has slowed down traffic, but many drivers have mentioned that they find the intersection more confusing than ever. Some drivers come to a complete stop with nothing in the intersection, while others drive through at speed. Pedestrians facing this unpredictable environment are still left guessing whether motorists will yield to them. Although no pedestrians have been harmed in the crosswalk since the improvements were implemented, there have been many near misses. Washington Hospital employees especially tell us that they feel they have to cross the street with extreme caution. For all those reasons, it's now time to install a traffic signal on Civic Center to regulate the flow of traffic and road and to protect pedestrians crossing at this busy intersection. Signed by Carol Dutra-Vinacci, the president of the foundation, Craig Silcox, treasurer, and Helen Kennedy, secretary, and myself. Thank you.
Thank you, Rod. Appreciate you coming to do that. Are there any other comments this evening from the public? Gail? Gail, you can stay there and comment.
This is for the Washington Hospital Healthcare District Board of Directors and Nancy Farber regarding the crosswalk safety. On behalf of the Service League Board of Directors, I want to thank you for your diligence and perseverance in improving the crosswalk safety of our hospital family. That includes staff, volunteers, visitors, and patients. Your timeless pleas before the City of Fremont, independent traffic studies, and traffic calming measures that have been implemented in the past year have been much appreciated. Unfortunately, in spite of these efforts, the risk of injury or death remains as motorists continue to ignore the flashing lights. We all know that we must cross with a defensive mindset that's no guarantee of our safety. A stoplight that will regulate the flow of traffic and provide a safe time period for pedestrians crossing is the only solution. With scores of volunteers, teens to seniors, using that crosswalk daily, we want to do all that we can to make sure that each one returns home safely. Thank you again for your persistence on our behalf.
I know. Dr. Lenny wants to speak. Glad to hear from him.
So at our August 18th Medical Executive Committee meeting, Ms. Farber asked for input and opinion from the medical staff regarding the crosswalk as well. And it was generally thought that the measures taken so far create a lot of confusion that might have imposed a false sense of safety. And it was decided, a motion was made that I write a letter to the board giving the medical staff opinion, which I'll read. Dear Chairman Stewart, at our latest MEC meeting, a discussion ensued regarding the crosswalk on Civic Center Drive between Washington West at 2500 Maury Avenue and Washington Hospital main campus at 2000 Maury Avenue and the associated safety concerns it represents. Despite some of the current measures imposed to improve pedestrian safety at this location, including the removal of shadow-causing trees, the narrowing of the traffic lanes from 4 to 2, and planters and other visible barriers to offer protection and increased flashing lights, we are still concerned that the risk of another serious event that could cause significant harm to a physician, hospital employee, or other member of the Fremont community is too great. A motion was made and unanimously passed by the MEC recommending consideration towards placing a signal light for automobiles with an associated pedestrian crosswalk signal at that site. We would support any efforts by the Washington Hospital Board to improve the safety of pedestrians in the vicinity of Washington Hospital.
Thanks to both of you. It's nice to get input from other sources. Are there any other comments from the public here that need to be considered? Then I will ask for comments from the board, if there are any on this issue that we need to discuss.
I'm always happy to speak on this issue because it's near and dear to my heart. One of our highest priorities at Washington Hospital is to have a safe environment for our patients and for our staff and for the community that comes and visits. And as the public is quite well aware, there have been numerous injuries, some life-changing injuries over the last several years in this intersection. I would agree with the previous commenters that the changes that have been implemented heretofore have improved somewhat, but actually increased some of the confusion and, as has been said, lent a false sense of security. I think the only way to really resolve this is by putting in the traffic signal. This will clearly define who has the right of way. As our consultant clearly stated, there is confusion as far as who respects the right of way. The pedestrian legally has the right of way, but whether that will be respected really was going to require a traffic light. I think this is money well spent. The crosswalk is our main conduit between the east and west of the campus at this point and will only increase in the years ahead. So I'm strongly in favor of this resolution.
Thank you, Dr. Nicholson. Any other comments from the board?
Just a few words. I agree with everything that's been said. I like the fact that the changes that are going to be made are a lot less confusing to the driver. In looking at the video, it seems like some people are still considering Civic Terrace a racetrack, and maybe even they're playing dodgem with people's lives, and that's not right. So I'm very glad to see that these safety measures are going to be put into place, because most people do respect a stoplight that goes red, green, and yellow. And hopefully that will help our staff, our visitors, and our patients who do cross that walkway. Everybody will feel a lot more safer, and I hope that this solves the problem. Thank you.
Thank you. We've taken quite a bit of time discussing this item tonight.
Could I just say one
Sure.
thing? I think that probably the need is well established based on the traffic now that goes between the two campuses. But I think we all have to look to future use, and with the construction of a new hospital building and an emergency room that will be 5 times the size of the one we have now, and an intensive care unit that has 50 beds in it and 68 more med-surg beds, the pressure on that intersection will only be the greater. We're also planning to move a substantial number of the Medical Foundation offices into Washington West, 2500 Maury. That will increase the number of people crossing back and forth between the two buildings. So the future use aspect, I think, only increases the urgency of getting this done.
Thank you, Nancy. We have spent a lot of time on this item tonight. It's an expensive item, but all of the value that we will get out of it is certainly worth it. And it's worth it for the safety of our staff, safety of our patients, and for the proper functioning of the hospital. I'm anxious to have this happen. Well, now, Christine, if you'll take a vote from the board. We have a motion and a second, so we're ready for a roll call vote.
Director Stewart.
Aye.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
Good. That motion passes. Thank you all for that, for all the reports on that this evening. This brings us to the end of our agenda for the open session this evening. We will now adjourn to a closed session. Thank you for your attendance. We reconvene to open session and announce that no action was taken during the closed session. There being no further items to consider tonight, this meeting is adjourned.